thank you again for inviting us to this symposium. We are really honored and pleased. So I shall present our results on the long-term outcome of late detected DDH. There's agreement that the aim of treatment is to achieve a normal hip joint and to avoid osteoarthritis. And however, there are several points of disagreement. Should traction be used? Should we use open or closed reduction? And the indications and type of procedures at later surgical correction. Long-term follow-up is important because the outcome deteriorates with the length of the follow-up. So the aim of the study was to see the outcome at an age of 58 years of late detected DDH treated with closed reduction, and which factors predict a satisfactory or less satisfactory outcome in these patients. The material consists of 60 patients, 74 hips, and they were treated between 1958 and 62. And the mean age at diagnosis was 17 months. They were from 6 to 34 months. And the initial treatment included skin traction, followed by closed reduction and hip spica cast. The aim of traction was to obtain gradual reduction of the hip. The position of the legs was in abduction, slight flexion, and moderate internal flexion and internal rotation. The average time in traction was 33 days, with a range from 16 to 65 days. Here's an example of a gradual reduction by traction. On the left, we see a patient aged 19 months at diagnosis with a dislocated left hip. In the middle, we see the X-ray after 2 weeks of traction, and to the right, after 6 weeks of traction, the hip is reduced and the spica cast is applied with legs in the same position. And at age 50 years, a good femoral head coverage and no signs of osteoarthritis. The age at hip reduction in our patients was 19.6 months. The average time at hip spica cast was actually 9 months, with a range from 6 to 20 months, which is quite a long time, of course. So additional surgery to improve femoral head coverage was necessary in 22 patients and 25 hips at a mean age of 11 years. Proximal femoral osteotomy with varization and derotation was done in 11 hips, and acetabular shelf operation with the Spitze technique in 12 hips. The acetabular shelf operation is a technique where a solid bone graft from the pelvic crest is impacted into a slot just above the acetabular labrum. On the left, you see a picture of a 12-year-old girl with a subluxated right hip. And to the right, you see a 4-year follow-up after Spitzeplastik with a good coverage of the femoral head. In this long-term follow-up, we included 59 patients with a patient age, mean age of 58 years. Patients were evaluated for osteoarthritis by measuring the joint space width. And we looked at the rate of total hip replacement, and we took a modified Harris hip score. The results are a combined and clinical radiographic outcome. A good outcome was defined by no osteoarthritis, and the Harris hip score more than 80 points, which was found in 39 out of 73 hips, which is 53%. Poor outcome was defined by osteoarthritis or a Harris hip score less than 80 points, which we found in 47%. So this slide shows the predictive factors for the long-term outcome in terms of satisfactory or unsatisfactory outcome. Age at reduction more than 1.5 years was associated with an unsatisfactory outcome, and the same was for the Severin grade 3 and 4 at skull maturity. These patients showed an unsatisfactory outcome. Risk factors was residual dysplasia. We see here a 15-year-old with a dysplastic left hip, and here at age 51 with severe osteoarthritis, and she was operated with a total hip replacement. 24 hips, 32% needed total hip replacement at a mean patient age of 48 years. And the Kaplan-Meier survival analysis showed after 30 years a survival of 100%, and at the age of 58 years a survival of 62%, but the less favorable survival for patients older than 1.5 years at reduction. They showed a survival of only 54% at age 58. So this slide shows a comparison with previous studies. Malwitz and Weinstein, the patients were 1.7 years at diagnosis, treated non-operatively. At age 31, 11% had received total hip replacement. Thomas and colleagues, mean age 2.8 years and treated by open reduction and osteotomy. At age 46, 31% had received total hip replacement. So we see an increasing frequency of total hip replacement with age, and in the present study, with an age at diagnosis of 1.5 years and closed reduction at age 58, 32% had received a total hip replacement. So no better outcome after open reduction and pelvic osteotomy than after traction and closed reduction. So the study may allow some conclusions. After a follow-up of more than 50 years, the clinical and radiographic outcome was satisfactory in 53% of the hips. Risk factors for poor outcome were age more than 1.5 years and residual dysplasia or subluxation and AVN. In these risk factors, if these risk factors are avoided, the hip will probably last more than 50 years. Thank you for your attention.